Hi, my name is Anne Delisle. I'm a dentist from Quebec City, Canada, and I have been placing implants for the past 15 years. I'm really pleased to give a short talk of 15 minutes on the 6mm implants. Just to let you know that this presentation is sponsored by Dentsply, Sirona. So the talk of today will be only on the 6mm implants. That's it. Back in the beginning of implant dentistry, the philosophy was the longer, the better. For many reasons, like the knowledge that we have on bone biology and biomechanics. And we all know that there's three main barriers why patients will refuse implant therapies. First, the fear of having pain, and also the cost and the time of the treatment therapy. And you know, I try in my practice to make things simple and more straightforward, you know, to make sure that people would go on with implant therapy. So today, the only reason why I will take in my practice longer implants is to achieve primary stability, to do immediate loading. So less is more by using short implants. Less complex surgery, less morbidity, and less time and cost. So you will have more case visibility, more case acceptance, and more happy patients. So in my practice, 90% of the implants that I will place are under 13 millimeters. And the average is probably 9 out of the 2,000 implants that we place every year for the past 30 years. So in 2009, AstraTech implant system launched a new size of implants because the shortest one was 8 millimeter at the time. So they launched the 6mm implants by 4. So 4 was the diameter of the implants. So it was the medium-sized platform. Because my partner and I weren't kind of cowboy type of practitioner, we start placing those implants with a very careful protocol at our clinic. And this protocol, it lasts for 2 years, just to make sure that we had time to look at results and success rate over time. So the protocol was to place the 6mm implants and then stage it with a cover screw and wait longer osseointegration time than usual implant size. Put a provisional on the implant for at least 6 months, just to make sure that we control every parameters and we don't see any bio or mechanical complications. And then we can finalize the case with the restoration. So our result was really promising at the time and really successful. So since 2011, we have a normal approach with those implants like any other implants. So the indications for those implants, at first, we only use them for single units, but now we place them or we use them for the whole project of implant treatment, like bridges, complete restoration for fixed or removable, partial denture. We love those treatments because we can clip those partial denture when we use a locator abutments, and we can place those 6mm implants either in the maxilla or in the mandibular. So over time, we place over 600 of those 6mm implants. But when we look at the science, here's some findings. Short implants with 6 millimeter or less in length should be carefully selected because they may present a greater risk for failure compared to implants longer than 6 millimeter. Well, over time in my practice, I came with the same conclusion. We tend to place those short implants in more compromised sites than regular size implants. So there's less bone availability, poor bone quality, or even too much bone density. So we kind of stress the elastic with those implants. So we have to expect more complication and failures only because of that situation. So we have to be really careful with case selection when we use those short 6 millimeter implants and adapt our surgical protocols. So first, a crucial thing is the diagnostic phase. So I use an implant software like Simplant One to make sure that I analyze everything before doing the surgery. And second, for those cases, I love to use a pilot guide, not the other guide like a safe guide. I use the pilot guide. It's the one that we only use the first 2 millimeter drill. So I can mark the proper positioning and angulation of the implant. And after that, I continue the surgery freehand. Why freehand? Because I can feel the bone, and I can manage really carefully the rest of the step of the surgery. So this, I found, this is essential for those cases. The other thing is the drilling protocol with those implants. I will adapt the drilling protocol with the bone density, like we use in all other cases. But I love to use with those cases new drills. And the thing that I always use is disposable drills for those cases, because I don't want to overheat the bone, and I want to really be careful with that particular situation. I over prepare the osteotomy, so most of the time I have a spinner implant, and the last thing, I stage those surgery with cover screw. So mainly I stage them, first of all, because I put most of the time spinners in really high bone density, and I stage them because I want to protect those implants from occlusal forces. So this is my main protocol for this particular implant. I wait also more time for osseointegration. I use ISQ measurement to confirm the implant stability over the healing phase. So, with those 6 millimeter implants, you need a bit of experience, because your experience will result in success in those implants. So with the Astrotech implant system, you have two choices of the system with the 6 millimeter implants. Either you use the TX or the EV. The TX, the only diameter available is the 4 millimeter one, so the medium platform. So that's why I love to use now the EV system, because you have the possibility of 4 platform, and the connection are the same as a regular implant, because this is a regular implant, even if it's short. So you have the same features as any Astrotech implant from the system. So first, the OsseoSpeed surface to optimize the osseointegration. This is crucial because it's only 6 millimeter implants. The micro threads the collar part of the implants is just essential because you avoid marginal bone loss, and because it's a 6 millimeter implants, you don't want to lose any bone. You want it all in the bone. The connective contour, you have that feature, and also the conical seal design. Well, the conical seal design is the connection, and with the EV connection, it's a one position connection. So it's just great. It's a conical, so really tight and precise fit. And you can do a full digital solution with this connection and this implant. And you don't worry about too much about the implant to crown ratio. Focus more on the type of connection that those implants will give you. So this is a conical one, so this is a really great connection. And the size of the connection, you will have to adapt the size. You will have to adapt the design of your restoration in consequence. So you have a great implant in your hand and a great connection. I prefer with those cases and all of my cases at the clinic, I prefer to do screw retain restoration because of its retrievability. So I use CAD-CAM Atlantis custom-based solution, and this abutment is so precise that I can avoid screw loosening and other mechanical complications. So, and also with this abutment, the custom-based solution, I can do and I can correct screw axis angulation, so I can always screw retain. So now that you have a big picture out of those 6 millimeter implants, well, let's talk about the indication. Mainly start with the maxilla indications. So you can avoid sinus lift with those implants, with the 6 millimeter implants, like in this case. But usually in the maxilla, well, there's less quality bone availability. We all know that. And also, well, sinus lift procedure, either it's a lateral window technique or the osteotome technique, are simple. And in my hand, I have almost no complication. So I don't place those 6 millimeter implants to avoid sinus lift. I prefer to do the procedure and use longer implants so I can have a better initial stability and long time stability also. One great indication to use a 6 millimeter implant in the maxilla is to avoid impacted teeth. So mainly the impacted canine, like in this case. So this is a case that I treated a few years ago with, a bridge. So in the early 2000s. And in 2014, we had a failure with the bridge. But because the canine wasn't in function, and because we had the chance to and the opportunity to use a 6 millimeter implant. So with the Simplant software and all the analyze and the diagnostic that we did and the software, we were able to use a 6 millimeter implant and avoid extracting this impacted tooth. So this is a great indication to use a 6 millimeter implants to make it simple for the patient. You can also do the same with curved roots to avoid them, like in this case. But the main indication why I use the 6 millimeter implants is when we have severe resorbed premaxilla. So this is a great indication in my practice. So when I use those implants, I prefer to splint them and have cross-arch stabilization. So I use bars, a complete overdentures, or a fixed restoration to do that. What I don't use much, and I try to avoid those kind of treatment, is individual attachment in the maxilla because of poor bone density and poor bone quantity, obviously, in those cases. Now let's look at the indication for the mandibule. So the straightforward cases, of course, for this 6mm implant. So this is the main reason why I use those implants, is to treat the posterior mandibular resorption cases. So this is great for single units or multiple units. So this is a patient that came to my practice and he got evaluated for implant treatment 15 years ago, but there was no solution other than a removable partial denture. But now with Simplant software, and the 6mm implants possibilities. So we did a virtual wax up that we integrated into our software, the Simplant software, and then we were able to go with the case with a pilot guide, like I described to you earlier in the presentation. The one other indication is for partial denture, that I will stabilize it with a locator that's going to be attached on the 6mm implants. So this is a really cost-effective and a really simple treatment that's going to make a really big difference in comfort for your patient. So think about it. Because I live in a region that, unfortunately, some people got their teeth extracted at a really young age. We have those kind of clinical views and those kind of advanced mandibular bone resorption with a really dense bone, like you can see on the screen. So I can treat those cases with the 6mm implants. I adjust the drilling protocol, like I told you previously, and I prefer to do bars or fixed, but mainly bars because of I can splint those implants, and it's easy for cleaning because most of the time the prosthetic height is really big, and it's simpler for hygiene for those patients compared to a fixed restoration. And sometimes, well, I see patients like that the only option, because of really severe bone resorption of the mandibule, we can only place 2 implants in the front part of the mandibule and restore this case with 2 balls attachment to make a more comfortable and retentive prosthesis. Also, and last example is the class 3. When you have a class 3 occlusal relationship with a U-shaped mandibule, well, what you want to do in those cases is to optimize the AP spread. But the thing is, when you have a really resorbed maxilla, well, sometimes you have a hard time to place implant in the backside of the mandibule. But with the 6mm implants, when you can place those implants, it's really great. So you can optimize those cases prosthetically. So let me conclude right now. So with all the cases that you saw previously in the presentation, while using 6mm implants, you saw that is simpler. You will have less complex surgeries, less morbidity, with less time and cost for the patient. And also, well, you will do more case feasibility, more case acceptance, but most of all, you will have more happy patients that will receive dental implant therapy. So I hope that wasn't too short. Thank you very much.